My patient is a 57-year-old female who was previously a grade school teacher. She was diagnosed with relapsing remitting multiple sclerosis about 15 years ago when she went to an acute care facility due to her pneumonia. She also reported that both of her lower extremities seemed to be weaker than usual. She noticed increased tingling in her fingers and numbness on the left side of her face. She was admitted to an acute intensive rehab facility. Her neurologist reported that she had a wide base ataxic gait, minor slurring of speech, and a bilateral tremor in the finger to nose test. Her CT scan was within normal limits, but her MRI revealed numerous white areas indicative of lesions. She takes 20 milligrams of prednisone by mouth 4 times a day, as well as 10 milligrams of Valium 4 times a day. She's been living on her own for several years now, with occasional help from her sister. She is alert, oriented, good memory, but she seems unaware of the seriousness of her condition. Her speech is difficult to understand at times. She also has difficulty with lower extremity extensor spasticity, and her right dorsiflexion is very limited. Her main goal is to regain her ambulation skills and go back to living independently. The main limitation I am focusing on is the patient's ambulation and her lower extremity strength, which will end up being crucial for her to get back to living independently. Ambulating not only throughout her home, but also her community is a goal that we should be working towards. In order to improve her ambulation, we need to address her lower extremity strength as well as her endurance, and hopefully get her away from using her assistive device. 2 impairments I'm focusing on. One will be the lower extremity spasticity. The other will be her limited dorsiflexion, especially in her left lower extremity. Helping her limit or prevent her spasticity will not only improve her safety when she's transferring, it will also improve her success when in ambulation. A couple interventions I chose include edge-of-bed marches, part of the Frankel exercises. Also Frankel exercises in bed, including the heel slides. Also going to work on some sit-to-stands at the rolling walker to improve the patient's flexion at the hip and knee for improved safety. I chose these interventions because I believe they will help her limit the amount of spasticity she has in her lower extremity. Improving the dorsiflexion will improve the patient's heel strike during gait, which will help the patient get towards her independent goal. I plan on performing a hold relax technique while in bed to improve the patient's dorsiflexion for a better heel strike. Improving the patient's heel strike will also help with walking. Energy tolerance throughout the therapy session is a major issue, so I plan on making sure my patient can keep up with the interventions and hopefully keep it under 10 minutes for her purpose.